Good day everyone! We are going to present a case study entitled Silent Tremors, Visible Struggles, a case study on Parkinson's disease. I am Cristalyn Tibayan and I am here with Alyza, Bianca, Limor, and Maria Julliana Mendoza.
Our case presentation is about Parkinson's disease, a progressive brain disorder that affects movement, balance, and coordination due to the loss of dopamine-producing neurons in the substantia nigra. So dahil dito, nagkakaroon ng patient ng symptoms tulad ng tremors, muscle stiffness, mabagal na paggalaw at hirap sa paggawa ng daily activities. Although the exact cause is not fully known, factors like aging, genetics, and environmental exposure may contribute to its development. While there is no cure, medications, therapy, and supportive care help manage symptoms and improve the patient's quality of life.
For the MAC case, our patient is patient X, a 65-year-old male retired teacher from Quezon City, Philippines. He has a family history of tremor-related illness from his father. Since retirement, he has led a sedentary lifestyle with limited physical activity. Upon arrival, he had a chief complaint of sudden worsening of tremors and stiffness during a community lecture. He fell forward, could not raise on his own, and showed exhaustion and sleep disturbances. For the history of his present illness, 5 years ago, the patient first noticed tremors in his right hand, which later involved both hands. Over time, he developed stiffness, balance problems, and difficulty initiating gait. His symptoms are more pronounced at rest but improve slightly with movement. He also reports disturbed sleep, constipation, and fatigue. On the day of admission, while attending a community lecture, he experienced intense tremor, rigidity, fell forward, and required assistance. His friends observed slowness of movement, difficulty speaking, and confusion. Concerned for his safety, they contacted his family who brought him to the hospital for emergency care. Down to the epidemiology, Parkinson's disease is the second most common neurodegenerative disorder worldwide after Alzheimer's. Globally, cases have risen sharply from 3.1 million in 1990 to 11.7 million in 2021, with over 1.3 million new cases each year. It mainly affects older adults, especially after age of 60, and men are more affected than women. Both genetic factors and environmental exposure like pesticide and air pollution contribute to the disease. In the Philippines, data remain limited. A 2007 nationwide survey found less than 1% prevalence, though case identification was weak. A community study in Quezon Province, 2016 to 2017, reported 0.55% overall prevalence, but 4.35% among those aged 60 and above, consistent with global trends. Local cases highlight environmental exposures and inactivity as possible contributors. Overall, Parkinson's is a growing public health challenge requiring better awareness, early diagnosis, and accessible treatment to reduce disability and improve quality of life. For its risk factors, Parkinson's disease developed through both non-modifiable and modifiable factors. For the non-modifiable, increasing age, risk rises sharply after 60. Male, family history, it doubles the risk compared to the general population. Genetic mutations such as leucine-rich repeat kinase 2, alpha-synuclein, Parkin, B10-induced kinase 1. And for the modifiable, environmental exposure such as pesticide, herbicides, solvents, and heavy metals. Long-term residence in areas with high air pollution, and sedentary lifestyle and poor diet. Additionally, head trauma, especially repeated concussions.
Now I will present the clinical presentation. First is the pertinent subjective data. During the assessment, the patient verbalized the following complaints. Mabagal na pong kumilos ang katawan ko. Nanginginig po ang kamay ko lalo na kapag nagpapahinga. At nahihirapan po ako maglakad at parang hirap ako magsimula ng galaw. The patient also reported increasing stiffness of the extremities, particularly upon waking in the morning, accompanied by episodes of imbalance and easy fatigability during ambulation. Difficulty in performing fine motor activities such as buttoning clothes, holding utensils, and writing was likewise expressed. In addition, the patient noted changes in speech, describing the voices as becoming softer and less clear over time. And for the pertinent objective data, objective assessment revealed findings consistent with Parkinson's disease. The patient exhibited resting tremors, bradykinesia, and muscular rigidity. Gait assessment showed shuffling steps, distressed arm swing, and difficulty initiating movement. Postural inability and impaired balance were also observed, increasing the patient's risk for falls. Speech was soft and slightly slurred, with reduced facial expressions noted during interactions. Next is the diagnostic and laboratory findings. For the neurologic and functional assessment, the patient demonstrated muscle weaknesses graded at 4 out of 5 in both upper and lower extremities, indicating decreased muscle strength compared to normal findings. Orbital rigidity was also present, which is a common manifestation of Parkinson's disease caused by increased muscle tone. The patient also exhibited resting tremors noted on the hands, which disappeared during sleep. During gait assessment, the patient showed a shuffling gait with decreased arm swing, which is characteristic of Parkinsonian movement. Grip strength was decreased, with findings of right hand strength at 18 kilograms and left hand strength at 17 kilograms. Functional independence measure shows a score of 55 out of 91, indicating moderate dependence in performing daily activities. In the Birch Balance Scale, the patient scored 38 out of 56, which suggests an increased risk for falls. The time out and go test result was 17 seconds, higher than the normal value of less than 12 seconds, indicating impaired mobility and balance. For the 6-minute walk test, the patient was able to walk 180 meters, which is below the normal range of 400 to 700 meters, reflecting reduced endurance and mobility. Based on the Hu, Hen, and Yar scale, the patient is classified under stage 3 Parkinson's disease, which indicates moderate disease progression with postural instability but still physically independent. Overall, these findings indicate impaired motor function, bradykinesia, postural instability, decreased balance, and reduced functional mobility consistent with the progression of Parkinson's disease. For the complete blood count or CBC, the patient hemoglobin, hematocrit, white blood cells count, and platelet count were all within normal limits. This finding suggests that there is no evidence of infection, anemia, or bleeding abnormalities. Lastly, in the electrolyte panel, sodium, potassium, and calcium levels were also within normal range, indicating stable electrolyte balance and no significant metabolic disturbance at the time of assessment. For the renal function test, the patient's blood urea nitrogen or BUN was 16 mg per deciliter, while creatinine was 0.9 mg per deciliter. Both values are within normal references ranges, indicating that renal function is normal and there is no evidence of kidney impairment. For the magnetic resonance imaging or MRI of the brain, the results showed no evidence of acute infarct, hemorrhage, or intracranial mass lesion. However, mild cerebral atrophy was noted. The impression states that there is no acute intracranial abnormality identified. These findings help exclude other neurological conditions that may mimic Parkinson's disease, such as stroke, brain tumors, or structural abnormalities. Lastly, the DET scan or the dopamine transporter scan revealed reduced dopamine transporter uptake in the basal ganglia, particularly in the putamen region. The impression of the scan indicates abnormal dopamine transporter activities consistent with Parkinsonian syndrome. This finding supports the diagnostic of Parkinson's disease because it reflects degradation of dopamine-producing neurons in the brain. Overall, the diagnostic finding supports the presence of Parkinson's disease while ruling out the other possible neurologic and systematic causes of the patient's symptoms.
For the pathophysiology of Parkinson's disease, to better understand it, let me explain the flow. First, we have the risk factors, the non-modifiable and modifiable risk factors. For the non-modifiable, we have three: the age, gender, and family history. The age, it is a natural process na bumababa ang dopamine-producing neurons sa substantia nigra. Kaya, after 60 years old, mas mataas na yung chance na magkaroon ng Parkinson's disease. Second is the gender. Mas mataas ang prevalence and mortality rate ng mga lalaki kumpara sa mga babae. Ibig sabihin, mas vulnerable sila na magkaroon ng Parkinson's disease. Third is the family history. In the case of our patient, his father has a tremor-related illness na nag-contribute sa pagkakaroon niya ng Parkinson's disease kasi nag-share sila ng genetic predisposition. And for the modifiable risk factors, we also have three: sedentary lifestyle or lack of physical activity, acute stress due to change of or imbalances of neurotransmitters, and third is the environmental exposures. First is the sedentary lifestyle or limited physical activity. It is because kapag hindi active ang katawan, mas bumibilis ang neurodegeneration at mas bumababa ang protective effect ng exercise. For the acute stress, gaya nung nangyari sa community lecture, stress can trigger or worsen symptoms kasi nag-iiba ang neurochemical balance ng brain. And for the environmental exposures, tulad ng pesticide, herbicides, solvents, and heavy metals, may evidence na nakaka-damage sila ng neurons at nagpapabilis ng dopamine loss. Once na trigger na ng mga risk factors, bumababa na ang production ng dopamine. So, nagkakaroon ng dopamine deficiency dahil sa pagkasira ng neurons sa substantia nigra. Dahil dito, tumataas yung relative acetylcholine activity kasi nga kulang yung dopamine. It leads to imbalance sa brain chemicals na nagkokontrol ng movement. So, dopamine is responsible for the smooth movement. So, kapag kulang siya, nagiging shaky, stiff, and slow na yung movement ng tao. And these imbalances caused to motor loop disruption and basal ganglia dysfunction. So, meaning to say, hirap ang brain na mag-coordinate ng voluntary movement. And included in here, yung autonomic dysfunction, kaya may constipation and orthostatic hypotension. This is included in Parkinson's because hindi lang movement disorder, pati body regulation apektado. Then, after that, dito na papasok yung mga clinical manifestations. We have motor and non-motor symptoms. For the motor symptoms, we have the cardinal signs. The resting tremors. Nagsimula siya sa right hand, ngayon bilateral na. Rigidity, yung paninigas ng muscles. Bradykinesia, yung hirap siya kumilos and hirap siya magsimula ng lakad. Then, postural instability, yung madali siyang matumba. Then, we have also associated signs such as shuffling gait, reduced arm swing, and freezing episodes. These are the usual cause kung bakit siya natumba at hirap siya kumilos. And for the non-motor symptoms, we have pagod and madaling ma-exhaust, disturbed sleep, constipation, speech changes or mahina na or hindi na siya masyadong naiintindihan, cognitive decline, confusion, mask-like face, wala na siyang facial expressions. So, madalas hindi napapansin pero malaki ang epekto sa quality of life. And lastly, we have the complaints and assessment findings present in our patient. So, makikita natin dito yung direct complaints ng pasyente namin. First, mabagal na pong kumilos. This is the bradykinesia. Then, nanginginig po ang kamay. This is the tremors. Nahihirapan na pong maglakad. Ito yung gait problems. So, as you can see, these are symptoms that are present in the disease process. So, meaning to say, yung mga lumabas or yung mga naramdaman ng patients, yung mga subjective data na sinabi ng patient is connected to the disease process, which leads to the diagnosis of Parkinson's disease. In summary, the pathophysiology of Parkinson's disease begins with the risk factors, the non-modifiable and modifiable, which lead to dopamine imbalance resulting in brain dysfunction and manifesting as both motor and non-motor symptoms experienced directly by the patient. Understanding this entire process is essential to connect theoretical knowledge with the actual patient presentation.
For our nursing diagnosis, impaired physical mobility. This is the actual nursing diagnosis because the patient already shows movement difficulties caused by Parkinson's disease, such as tremors, muscle rigidity, slow movement, shuffling gait, and poor balance. These symptoms affect the patient's ability to move and perform daily activities. Next is the risk for falls. This diagnosis was identified because the patient has impaired balance, postural instability, muscle stiffness, and difficulty walking, which increase the chance of falling. The patient also has a history of falling during a community lecture. Lastly is the potential for self-care deficit. This is a potential diagnosis because the progression of Parkinson's disease may eventually make it difficult for the patient to perform self-care activities independently due to tremors, decreased coordination, and muscle rigidity.
To start with the management, we have health promotive. Health promotion focuses on maintaining overall well-being. Balanced nutrition, regular exercise, and stress management help strengthen the body and mind. Social engagement and mental stimulation are included because they preserve cognitive abilities and emotional reliance. Patient and family education is essential to build healthy habits that improve long-term quality of life.
Disease promotive, preventive measures aim to reduce complication and progression of disability. Regular follow-up consultation, adherence to prescribed medication, and monitoring of symptoms are essential. Fall prevention strategies such as maintaining a safe environment, using assistive devices, and removing hazards at home and encouraged.
For curative and restorative, although Parkinsonians has no cure, treatment focuses on controlling symptoms and restoring function. Pharmacological therapies improves movement and reduces tremors. Restorative care, such as physical, occupational, and speech therapy, is included to maintain independence and daily functioning.
Determination and management of pain. Parkinson's disease is primarily caused by degeneration of the dopamine-producing neurons in the brain, particularly in the subclavian medulla. Management focuses on addressing factors that worsen symptoms such as stress, poor medication compliance, and lack of mobility. Continuous neurologic assessment is important to monitor disease progression.
Drug therapy. Medications are essential in managing Parkinson's disease symptoms. The patient may be prescribed levodopa combined with carbidopa to improve dopamine levels and control tremors, rigidity, and bradykinesia. Other medications such as dopamine agonist and anticholinergic drugs may also be used depending on the patient's condition.
For prevention of infection, patients are prone to respiratory infections due to swallowing difficulties and reduced mobility. Preventive measures include oral hygiene, adequate nutrition, coughing and deep breathing exercises, and monitoring for aspiration or pneumonia. This is included to reduce life-threatening complications.
Supportive management due to impaired mobility and muscle rigidity, the patient may require assistance with activities of daily living. Regular exercise, proper positioning, use of assistive devices, and fall precautions are necessary to maintain safety and mobility. Skin care and repositioning are also important to prevent pressure injuries.
Due to rigidity and poor balance. Fall precautions, assistive devices, regular repositioning, and range of motion exercises are important to maintain safety, prevent pressure ulcers, and improve mobility. For the prevention of complications such as falls, aspiration, malnutrition, constipation, and depression must be prevented through continuous monitoring and nursing care. Early identification of swallowing difficulties and mobility problems help reduce the risk of severe complications.
And the last one is rehabilitation. Rehabilitation is vital for long-term management. Physical therapy improves balance, posture, and mobility. Speech therapy addresses swallowing and communication difficulties. Occupational therapy helps maintain independence in daily activities. This is included to maximize quality of life despite disease progression.
Next is the pharmacological management for Parkinson's disease. The first medication is carbidopa/levodopa, which is considered the gold standard treatment for Parkinson's disease. Its generic name is carbidopa plus levodopa with the brand name Phenomene. It is classified as an anti-Parkinson's agent and dopamine precursor. For its mechanism of action, levodopa is converted into dopamine in the brain to improve motor function, while carbidopa prevents the premature breakdown of the levodopa before it reaches the brain. This combination increases dopamine availability and helps reduces Parkinsonian symptoms. The medication is indicated for Parkinson's disease, particularly for symptoms such as bradykinesia, rigidity, and tremors. However, it is contraindicated in patients with narrow-angle glaucoma, history of melanoma, and hypersensitivity to the drug. Possible adverse reactions include nausea and vomiting, orthostatic hypotension, dyskinesia or involuntary movements, hallucination, and drowsiness. As a nurse, important interventions include monitoring the patient's vital signs and blood pressure, assessing improvement in mobility and tremors, and instructing the patient to avoid sudden position changes to prevent dizziness and falls from orthostatic hypotension. The medication should also be administered on time for maximum therapeutic effect, and the patient should be observed for signs of dyskinesia and hallucinations. For the second medication, pramipixole is the generic name, while the brand name is Mirapex. It is classified as a dopamine agonist. For the mechanism of action, pramipixole works by stimulating dopamine receptors in the brain. Since patients with Parkinson's disease have decreased dopamine levels, this medication helps improve motor activity and movement control. For the indication, pramipixole is indicated for both early and advanced Parkinson's disease. It helps reduce symptoms such as tremors, rigidity, and difficulty in movement. Contraindications is the medication is contraindicated in patients with hypersensitivity or allergy to the drug. It should also be used continuously in patients with renal impairment because the drug is excreted through the kidneys. For the adverse reactions, the common adverse reactions include dizziness, sleep attacks or sudden sleep episodes, hallucinations, hypotension, nausea. And for the lastly, the nursing action is monitor for excessive daytime sleeplessness, assessing for changes in mental status such as hallucinations, instructing the patient to rise slowly from bed to prevent orthostatic hypotension, monitoring kidney function during prolonged use. Lastly, the selegiline. The generic name is selegiline and the brand name is Eldipril. It is classified as an MAO-B inhibitor. The mechanism of action is selegiline works by blocking the monoamine oxidase B enzymes, which is responsible for dopamine breakdown in the brain. By preventing dopamine destruction, the medication helps increase dopamine levels and improve symptoms of Parkinson's disease. For the indications, Cristalyn is indicated as the adjunct treatment of Parkinson's disease, meaning it is commonly given together with other anti-Parkinson's medication. For the contraindications, the medication should not be used together with certain antidepressants or opioids because it may cause serious drug interactions. It is also contraindicated in patients with hypersensitivity to the drug. Common adverse reactions include insomnia, headache, dizziness, and hypertension. For the nursing actions, important nursing responsibilities include monitoring the patient's blood pressure regularly, assessing for possible drug interactions, administering the medication early in the day to prevent insomnia, observing for signs and symptoms of serotonin syndrome. In summary, both pramipixole and selegiline are important medication used in managing Parkinson's disease. Parpixole acts by stimulating the dopamine receptors, while selegiline prevents dopamine breakdown in the brain. Proper monitoring and nursing care are essential to ensure patient safety and therapeutic effectiveness.
Our short-term goal is for the patient to remain free from falls, demonstrate safer movements with assistance, understand safety precautions, and show improved mobility with less stiffness and fatigue. For our long-term goal naman is for the patient to maintain the highest possible level of independence, use assistive devices safely, participate in rehabilitation programs, and of course, adapt effectively to progressive mobility limitations caused by Parkinson's disease.
Lastly, we have our discharge plan. So, the first part of the discharge plan focuses on medications. The patient must strictly follow instructions for taking anti-Parkinsonian drugs, such as levodopa, carbidopa, dopamine agonists, and MAO-B inhibitors. Proper dosage and timing are critical to ensure effectiveness. Education for both patient and family is necessary to understand possible side effects, including nausea, dyskinesia, and orthostatic hypotension. Next is environment and safety. The home environment must be modified to reduce fall hazards, remove clutter, install grab bars, and provide adequate lighting. Assistive devices such as canes and walkers should be used when needed. Family members must supervise walking until the patient demonstrates safe balance control. This is included because safety is a priority in preventing further injuries. Third, exercises and rehabilitation. Daily physical therapy is required, focusing on balance, posture, and gait training. Stretching and low-impact activities such as walking, tai chi, and swimming should be encouraged. Occupational therapy is also needed to improve fine motor skills and teach essential daily living tasks. This is included because exercise and rehabilitation help maintain independence and mobility. Fourth, diet and nutrition. A balanced diet rich in fibers prevents constipation. The patient should drink 6 to 8 glasses of water daily to stay hydrated. High-protein meals must be avoided before taking levodopa because they interfere with absorption. This is included because nutrition directly affects both symptoms and medication effectiveness. Fifth, psychosocial support. Counseling services should be provided for depression and anxiety along with coping strategies. Participation in support groups for patients and families is encouraged. Family involvement in care planning is essential to provide emotional support and ensure compliance. This is included because Parkinson's care must address emotional well-being, not just physical health. Sixth, follow-up and continuity of care. Regular outpatient appointments with a neurologist are necessary to adjust medications. Monitoring of symptoms, progression, and complications such as dyskinesia and cognitive decline must be done. The first follow-up should occur within 1 to 2 weeks after discharge, then every 1 to 3 months depending on stability. This is included because Parkinson's disease is progressive and requires continuous monitoring. Lastly, health teaching. The patient and the family must learn how medication effects vary throughout the day. Training should include strategies for freezing episodes such as visual line keying and rhythmic counting. Education on proper sleep habits and stress management techniques is also important. This is included because teaching empowers the patient and the family to manage the disease effectively. Overall, the discharge plan is holistic, covering medications, safety, rehabilitation, nutrition, psychosocial support, follow-up, and health teaching. Each part is included because Parkinson's disease affects not only movement but also lifestyle, emotions, and overall quality of life. That's all. Thank you for listening. I hope you learned something. Bye!